Good evening and a warm welcome to all of you to IHW Spotlight, a web show brought to you by IHW Council, where today we'll be talking about fertility preservation in cancer patients. This program is supported by CIPLA. I'm Anisha Nayar, Dhawan, your host for the show. Now, the mere diagnosis of cancer is usually a shock for most patients. Hardly anybody sees it coming. The patient's mind space is immediately occupied by perhaps a feeling of guilt, worry about their health, the logistical and the financial arrangements for their treatment, and the side effects of the treatment. During this time, planning for the future may not seem to be like the most pressing or urgent thing to do, but there are a few decisions that need to be taken to ensure that young cancer patients can enjoy a fulfilling, healthy, and happy family life in the future. Did you know that cancer and cancer treatment can affect the ability of patients to conceive children and have families in the future? Is there something that can be done so that the ability to have children can be protected? To discuss this, we have an eminent panel of experts joining us. Please welcome Dr. Jyoti Wadhwa, Director, Medical Oncology, Medanta Cancer Institute, and Dr. Jaydeep, Obstetrician and Gynaecologist, IVF Consultant, Ashwini Maternity and Surgical Hospital Center for Endoscopy and IVF. A warm welcome to both of you for joining us on the show. We are also very pleased to have with us Dr. Professor Jaydeep Malhotra, Director of Rainbow IVF, and very soon we'll be joined by Dr. Chetan Deshmukh, the Consultant Medical Oncology at Deenanath Mangeshkar Hospital. Thank you all for joining us. It's a pleasure to have you with us on this show to talk about these issues, which I think very few people know about or even talk about. Now, the first question that comes to my mind is, and I'll come to you, Dr. Malhotra, on this. When people think of cancer, they think cancer is the disease of the aging. Only old people get it. So old people, you would assume, have already settled their families. Do they need, fertility preservation? Who is this fertility preservation for?
Yeah. Hi, Anisha. Thank you for having me on the panel. It's a very important issue. And whether it's any age group, first important thing is that, yes, older age group, we think that cancers happen more in older age group, but that's not really true. There are many types of malignancies which are very much happening in much younger age group. And those are the people, and especially, when the survival today with any kind of treatment for malignancies is improving every day. So today we are not only looking at people, especially young people, on making them, survive, which we used to think, but we are also looking at their quality of life, which is very important. And as the longevity increases with the disease and disease-free, they would like to lead a normal life. So there's a huge role of fertility preservation, which you and I and everybody else should be really talking about.
Yes, Dr. Malhotra, but this is something that barely people talk about. So I would like to know from you, what have you seen in your experience? So Dr. Wadhwa, could you give us an example? Have you seen a young patient who was not even aware that, either cancer or even cancer patient could affect her future life, her family life, her ability to have children, or a man? Does this affect a man also, or is it only for women? Could you give us some real life examples that you may have seen in your practice?
Yeah, a very good question and a very pertinent one. And first and foremost, let me compliment IHW to give us a platform to discuss this relevant and very important issue. Cancer diagnosis often instills fear in the minds of not only the patient, but the entire family. And often this very important issue of oncofertility gets neglected on the way. So it's very important now that we are seeing more and more young patients with cancer that we discuss this issue, because we know that with improvements in the treatment, they are going to live longer and they are most likely going to get cured of cancer. So this issue is very pertinent and very important. In fact, all patients of reproductive age, whether men or women, should undergo this oncofertility counseling by these specialists. And as you rightly said, it does not matter only to women, but equally to men. And there are ways to address the preservation ways differently for both men and women. So since we see many more younger people now, it becomes much more relevant to be discussing this issue at the diagnosis, in the initial few meetings itself, bring up this topic and discuss with them.
All right. Dr. Jaydeep, what have you seen in your practice? Are you seeing younger patients? Because, when we talk about cancer care, we're hearing this from a lot of oncologists saying that India's demography is such that there are a larger population of younger people, which is why, compared to the West, you will see a larger pool of cancer patients who are younger in our country. Is this something that you've seen in your practice? And would you perhaps give us an example of where you counseled a cancer patient, or the cancer patient asks you whether they should plan this far ahead or life after cancer treatment?
So I think your question actually has two separate parts. And the first part really is whether there is a fair number of patients who develop cancer in the reproductive age group, which is when fertility preservation comes into play. Because if an elderly person develops cancer, of course, there's no question of fertility preservation. And the answer to that question is absolutely yes. There is, however, one caveat that one needs to understand, that the primary physician for most kinds of cancer that take place in the reproductive age group are the oncologists. So in a way, the oncologists act as gatekeepers for the whole oncofertility subspecialty. And that's why I think it's important to realize that oncofertility or fertility preservation in cancer is actually a grand collaboration between oncologists, that means the people who specialize in cancer, and fertility specialists, that is the people who actually do the fertility preservation. I would say that most of the patients that we see who come to us for fertility preservation do not come to us on a direct basis. That means it's not as if they are diagnosed with cancer and they say, okay, I've been diagnosed with cancer and now I want to preserve my fertility. It's usually that the oncologist gives them the option, saying that you have this kind of cancer. This kind of cancer will affect your fertility in the future. And when it affects your fertility, you have the option now of preserving your fertility. And so go to this subspecialist who's a person who can help you with fertility preservation. And in our practice, that's the way it generally works. I'll give you two examples very quickly. We had one young person who had developed a cancer of the blood. It's called non-Hodgkin's lymphoma. And that is, if I understand correctly, got a fairly good prognosis and a fairly good survival rate. Unfortunately, the medications that are given for that affect the sperm generation. And because they affect the sperm generation, it was a good idea for him to give us some of his sperm samples. And we preserved those sperm samples. And then a few years later, he came back and he could successfully have a pregnancy from that. In fact, if you really see, it's much easier to perform fertility preservation in males than it is in females. Because in females, you get the chance to harvest the gametes only once a month. And therefore, you can harvest gametes much easier in males. Another example would be a patient who came to us with a diagnosis where she had a cancer of the jaw. And it's extremely rare, but that cancer required the chemotherapy. And that chemotherapy obviously affects the eggs and reduces the number of her eggs. So before she started the chemotherapy for the cancer, we could manage to retrieve almost 25 eggs from her, and we preserved them. She has not come back to us yet for subsequent pregnancy because this has happened just 6 to 8 months back. But we have around 24, 25 oocytes for her. And I'm sure that when she comes back and decides to become a mother, we will be able to help her. So these are some practical examples.
Okay. Dr. Tank, just for my reference, this female patient that you spoke of who had cancer of the jaw, what was her age?
She was actually 22.
22, cancer at 22.
Yes, it's rather rare, but that was just the example which came off the top of my head.
Okay, that sounds very extreme if you ask me, because you expect young people to be full of life and be healthy. At when we were young, we would have bad diet, no exercise, overwork, work 16 hours a day, we still be fine. And perhaps this is a lifestyle that nobody should have, and this is what leads to these lifestyle diseases. Dr. Malhotra, Dr. Tang gave us two examples. I'm trying to understand, cancer treatment supposed to make me better. How does it then affect my body so badly that I may not be able to conceive in the future? Is it the cancer that affects my fertility, or is it the treatment that affects my fertility?
There are lots of things which we need to understand. First is like, yes, the cancer itself can also affect fertility, but the treatment, again, every kind of treatment, whether it's surgical, chemotherapy, radiation, they all have an effect on the fertility. And that's why we are looking at the options, because sometimes when you are looking at, let's say there is a cancer, as Jaydeep was saying, that, cancer of the jaw, and you don't really think, yes, it's going to affect the fertility, whether it's a male or a female. But yes, the chemotherapy agents which you're using, or the radiations which we are going to use, they have, depending upon the type, the dose which is being used, they're going to have different kinds of effects. And again, let me put it similarly, like people have leukemias, acute lymphocytic leukemia. Now, mostly they will have, lower risk. At what age it has happened is, again, something which I'm sure the cancer specialist will throw some more light on it, has an effect. What dose of radiation they're going to receive is going to have a different kind of effect. So it is something which we need to understand. That then there is another cancer, let's say, which is affecting the organ directly, like ovarian cancer, or a tubal cancer, or a uterine cancer, or a cervical cancer in women. They're going to have a direct effect on the fertility, because they're obstructing in a way, they're obstructing the function, they're anatomically disturbing. And plus, similarly for men also, there would be similar effects. So we need to understand that, yes, they have dual effect. One, because of their presence itself, and second, because of the treatment which we offer for them.
All right. Dr. Chetan Deshmukh is also with us. Dr. Deshmukh, I'm just trying to understand that if it is a young patient diagnosed with cancer, is there any way by which I can get away without fertility preservation? Either by the type of cancer or by the kind of treatment, or does this seem like necessary for every young cancer patient to undergo if they want to have families in the future?
Yeah, thank you for inviting me here. Your question is, does every patient need to undergo or does every patient of cancer get this problem of infertility? Is that what you want to know?
Young patient.
Yeah.
And does he have to do preservation, or can he somehow get by despite the medication, despite the cancer?
Not really, because if you look at the most cytotoxic drugs which we give for chemotherapy, the chances of developing permanent sterility are to the tune of 22 to 25%. Irreversible sterility.
Sorry, Dr. Deshmukh, I will request you to please explain to us what is cytotoxicity.
Okay.
What exactly are you talking about?
Okay. I'm sorry. So the chances of developing the inability to conceive permanently are about 22 to 25%, and this is with the worst possible chemotherapy. So the drugs which we use for treatment of cancer, they do suppress your fertility or your ability to conceive, but it is usually for a brief period of time. Permanent sterility or permanent bad effects happen in about 20 to 25% only. They don't happen in all patients. That too, it depends on the type of medicines, which Dr. Malhotra rightly said, that it all also depends on the type of treatment which you have offered to the patient. Now, say for example, a patient has undergone a uterine surgery, then the chances of she conceiving are going to be very, very less. Compared to a lady who has undergone breast cancer treatment, the chances of she conceiving are still very good. Say if somebody has undergone treatment for a bone tumor in very early age, or somebody who has undergone treatment for a brain tumor or some other kind of tumor, then the chances of conception are good. But if some surgery, some procedure, it may be surgery, it may be radiation therapy to the lower abdominal area or to the genitourinary organ, then obviously the chances of fertility are going to go down. Having said that, a fair amount of young people actually do end up conceiving even after cytotoxic treatment by some way or the other. Now, the proven therapy for preventing this kind of an occurrence is there only for breast cancer. The study has been done only in breast cancer patients where you put the ovaries to sleep. In simple terms, to put it in a very, or rather an oversimplified way, we put the ovaries to sleep. We give you an injection once every month and the ovaries are allowed to go off to sleep. So during the chemotherapy, ovaries don't function. After chemotherapy, you stop the drug and the ovaries can start functioning again, or you aim that the ovaries will start functioning again. So that is one way which has been shown to be effective in breast cancer only. But we sometimes use the same methodology in treating lymphomas or treating some other cancers, which actually has no scientific rationale because the study is only for breast cancer. The other methods, prevention works out to be the best way in fertility preservation rather than treatment. Most of the fertility preserving strategies like you do ovarian oocyte preservation or sperm banking, these are things which are quite tricky. Now, let me give you an example for sperm banking. Say a patient of cancer who has stage 1 cancer, he walks into my office today. He has a very early stage cancer, so I can afford to tell him that you can collect your sperms over a period of say a week, 10 days. But when a patient gets diagnosed with cancer, if I tell him to stop his treatment for 8 to 10 days, it is usually not acceptable to him. For him at that point of time, the only thing on his agenda is cancer treatment. So fertility and other things are not even on his horizon. He's looking, they are far things. Right now, he wants treatment for his cancer ASAP. And so fertility.
That is understandable. That is definitely understandable.
Semen preservation is not a very difficult job, but nevertheless, people don't opt for it. The second thing is prohibitive cost. The cost is about 50 to 75,000 per 6 months. And this is over and above the cost of therapy. And if you are planning to preserve the sperms for a good 2 years or 5 years, you look at the cost, it's going to run in lakhs. So how will people afford it?
Is that so? Does cryopreservation bill come to you every year?
I want to add something here. Yeah. Can I come in?
Yes, Dr. Wadhwa, go ahead.
Since I am a medical oncologist who treats cancer with medical treatments, so I want to emphasize that all cancer treatments are not alike. We have not only chemotherapy to treat cancers, we now deal with monoclonal antibodies. We deal with tablet forms of treatment called tyrosine kinase inhibitors. We have drugs like anti-HER2 agents for breast cancer, which we commonly use. So the effect on fertility is not same for all the drugs. In fact, even for chemotherapy, we classify them as to whether there's high risk or intermediate risk or low risk. So high risk would be something like the drugs that we use, say, for breast cancer, TAC or dose-dense AC. These are the commonly used chemo regimes. So the patient has to be aware that patient could turn sterile or infertile and therefore should act in the beginning itself, when all we need is a 2 weeks period to plan, future fertility preservation. The other thing is that we use stem cell transplants or high dose chemotherapy and bone marrow transplants. So there also we have to be very, very careful and alert and discuss the subject of fertility preservation before we start the treatment, because we know that the risk of infertility is very high with the use of these high doses of chemotherapy. Also, we need to know that there are some drugs like these monoclonal antibodies and targeted therapies for which the risk is unknown. However, there are certain drugs which are very low risk, some platinums like cisplatin or lapatinib or trastuzumab, very commonly used drugs for breast cancer, which are not gonadotoxic at all. So one has to
Dr. Wadhwa, when you're talking about risk, you're saying risk to fertility, high risk to fertility and low risk to fertility, right?
Yes, very true.
Right.
Yes.
I think Dr. Malhotra also wanted to add something.
No, I just wanted to add, fertility preservation, especially for men, is not as expensive. It's so simple to preserve a semen sample. It doesn't take much, and it doesn't take much even to maintain it. But yes, I do agree with Chetan that fertility preservation for women is a little more expensive. But for men, it's very simple, whether it's like semen or even sometimes that if you want to preserve testicular tissue also, it doesn't really take much. So I think that message should go clear. But yes, women will have, some more financial expenses.
Right. Now, what is happening is that cancer.
If I may just
Yes, sir.
add to
Yes, please go ahead, Dr. Jaydeep.
everything what everyone has said so far. I completely agree with Dr. Chetan Deshmukh that when you utter the word cancer, the priority is never fertility preservation. And that's the point I made about the fact that the oncologists actually act as gatekeepers. And I think it is up to the oncologist, because they are in the best position to decide who is a patient who's at high risk of having a reduction or loss of fertility vis-a-vis the patients who are not. As Dr. Jyoti Wadhwa just said, there are different kinds of drugs with different kind of risk profiles. But I will just say this one thing. If you have a patient who has been made a diagnosis of cancer, she's sitting in front of you or he's sitting in front of you, and he or she asks the medical oncologist or the surgical oncologist, can you assure me that after this treatment, I will be fertile? I think that is the gold standard question that has to be addressed. If the oncologist, medical or surgical, can with 100% confidence say, yes, this is a treatment which is not going to affect your fertility, then by all means, don't talk to the patient about fertility preservation. But even if there is a 20 to 25% chance in the context of things or in the long run of things, even 20 to 25% chance of losing fertility is quite significant. And I think that is where I said it is actually supposed to be a grand collaboration. And the problem really is that we do not have structured counseling, or we do not have structured oncofertility units. A patient can go and speak to and I think
Right. Dr. Deshmukh, I'd request you to please mute yourself. We are unable to hear Dr. Jaydeep. Yeah, please go ahead.
Yeah, so it requires two sets of awareness. It requires awareness from, and I'm using this word consciously, the consumers, and it requires awareness from the physicians, the healthcare providers, and indeed the entire healthcare ecosystem also. Thank you.
All right. Dr. Chetan, you've heard what the other panelists have said. And you said that time may also be a constraint. I want to know from your experience, when you see young cancer patients, a majority of the cases in early stages, where then it is possible to go in for fertility preservation because you may have the luxury of time, or are these younger patients also being diagnosed with aggressive cancers and hence time is a luxury they don't have? Dr. Deshmukh, the question is for you.
Yes, sorry. I'm sorry. I was just cutting another call. So,
I request you to turn your camera on also. We can't see you.
Sure. Yes, I agree that young patients, of course, are the ones which are perfect candidates for fertility preservation. And if they present in an early stage, then yes, fertility preservation is definitely on the cards, no matter which cancer we are treating. For advanced cancers, of course, it is usually not even brought up by the patient. So doing strategies for fertility preservation is usually not even employed. But for young patients, and if the patient has a potentially curable cancer, it is always brought up during the initial discussion as to would you like to preserve your fertility. So that goes without saying. And I completely agree with Dr. Jyoti that whenever we have an opportunity to use a drug or any therapeutic modality which will not affect the fertility at all, it is always preferred. That goes without saying. And I again would like to repeat that it is usually at the first counseling when I open up too many things, most of the patients they get very confused. So I usually tell them to go back and come back with some more questions. And during the second round of discussion, I gradually introduce this topic that what about fertility? Would you like to think of fertility preservation and something like that? But
okay.
I must say that at least half of my patients don't even want to think of it at the outset. Half of my patients are just not acceptable to this idea of waiting for a week or 10 days. Now, sometimes these procedures, even semen collection has to be done gradually. It cannot be done in a day. It needs to be done over a period of 3 days, 5 days, sometimes even 7 days, depending on the yield. And that many of the young patients they want treatment yesterday. They want it now. So then counseling them is a challenge. And I completely agree. We have a team, we have a separate department which looks after fertility preservation, and we do send them across to counseling. And they are usually just in the next building, so we don't even have to send them outside the center. They are very much in the center. But there is, I must say that the uptake is rather reluctant. I don't see a lot of uptake for fertility preservation as of now.
But the good thing is that your hospital at least has this provision, because cancer treatment is usually it's a team of people working together for the treatment. You have oncologists, you have radiologists, you have the counselor. A lot of people work together, and if any one of them are also thinking about this, it will really help the patient. Dr. Wadhwa, Dr. Chetan was saying that, patients want treatment. They're not even thinking this far off. Then how do you counsel? Do you involve the families? See, if a patient is very young and they have not even, perhaps thought of marriage or are busy with their careers, they may not be thinking of this now. And later on, they may, have regrets. So do you involve family in the counseling? How do you go about this? Plus, what kind of transparency is required? Because, in our country, all this is such a touchy social subject, for people who have to get married in the future. What will they say to their prospective spouses? How to be transparent, what to say. So are these issues also something that you discuss, maybe not only with the patient, but also with the family?
Yeah, very important question. So as I would like to put it is that for, how do we decide as oncologists as to who to discuss this issue with or this subject with, whom to discuss the subject or topic of oncofertility. So we must consider not only the patient, but also the couple or the family, I would say, being in India. We also should take into consideration what type of cancer and what stage of cancer we are dealing with. What is the likely outcome with the offered treatment? So all these three components of the treatment process must be taken into consideration before we discuss the subject of oncofertility. Also, we must remember that this is the only chance that we have before we start the patient on treatment. That's the only window of opportunity that we have. For men, it's much easier. It can be done in a much quicker fashion. For women to undergo fertility preservation, we need 2 weeks for, ovarian stimulation and then egg cryopreservation. So we have to see as to who's that right candidate, say for women who can wait, in whom the cancer treatment can wait for 2 weeks. So in our practice, so I work in a place which is a tertiary care center, very high load of cancer patients. We see on daily basis, a lot of young patients with breast cancer in particular. So these are the ones who are being, going to undergo some anti-cancer treatment or chemotherapy before they even have to undergo operation. So if they are at the right stage of the disease and the treatment can wait for 2 weeks, why not? We should discuss oncofertility with them and get them across to a good fertility expert so that they can undergo ovarian stimulation, oocyte cryopreservation. And then we also use some injections, as Dr. Chetan had mentioned in the beginning, that we use some injections to suppress ovaries, put them to sleep. So why not? They can be started at the right time, so that when they are cured of cancer, they can enjoy the other aspects of life also in the future.
Right. Dr. Malhotra, Dr. Malhotra, I wanted to ask the same question to you about the counseling of young cancer patients who may not be thinking of marriage or that far ahead of fertility. Now, in your practice, most of the patients who come to you for fertility treatment perhaps are not cancer patients, and they have been trying for very long and they are really affected by infertility. But the young cancer patient at this point in time doesn't understand that. He or she is more concerned about what she's going through now. So, while the medical oncologist will suggest that, why don't you speak to a fertility specialist? How can they impress upon the cancer patient who's worried about other things? Is family's involvement important here?
Actually, the counseling is the most important part. And then the assessment, it doesn't really happen like this. There are tumor boards who'll sit down, who'll, discuss the treatment plans. They'll also understand which one has a low risk of subfertility or a low risk of survival, let me say it that way. So it is something like it's an informed decision-making with the family, especially for young patients, because they may not be able to understand. The challenges are very different on the ground level, because young patients may not understand, but they will come with relatives who are not as understanding as well. So it is not so simple as when we talk, because ground level problems are absolutely different. But the point is that the message has to be driven across, because especially for a patient who's going to make it to a good survival rate, after a few years, we'll definitely come back and realize and say, oh, why this option was not really given to me. And again, it's not only one of the challenges. The second challenge is finances. We don't have insurances covering up. We don't have, a lot of people will only think of cancer treatment in itself is so costly. And an additional treatment of fertility preservation may not be on their page at that point of time. But I have seen many people who are today, aware and realizing and going for it if they're given the option. And I absolutely feel that this is a cumulative decision which is taken by a group of people on the adequacy and also on who's going to really benefit from it in the long run. So it is not only that I will decide or an onco person will decide, it is number of people who sit together.
All right. So we have discussed a few of the challenges that are there for that come in the way of fertility preservation for cancer patients. Dr. Deshmukh, we understand that the eggs, the sperms, the ovaries, the organs may get affected. Are there other challenges that also rise for there are side effects of treatment or the cancer that can then affect fertility later?
Yeah, thank you for bringing it up. It is a very important topic, especially for males. Erectile dysfunction is something which is not touched upon, even for non-cancer patients. Say people who are suffering from long-standing illnesses like hypertension, diabetes, either because of their disease or because of their treatment, they suffer from erectile dysfunction, and it is not brought out by even these people. For cancer patients, it's even they don't bring it up voluntarily. We have to probe and ask. Now, since we are looking at young people, fertility preservation is more relevant in young people. Now, these young people suffer from certain cancers, aggressive rectal cancers, germ cell tumors, where they may undergo dissection of the nodal dissection, which can affect nerves, which supply the genitalia, or radiotherapy to the pelvis. This can affect their erectile function, and as a result, they are unable to perform. And then that, of course, has a big bearing on fertility. So we've had patients who come after extensive pelvic surgeries, and they are married, but they are unable to have a child, because otherwise they may be normal. The person may have all his hormonal workup will be perfectly normal. But because of this problem, he will not be able to he will not be able to father a child. Now, this problem has to be probed. It has to be voluntarily asked, because many people, out of sheer embarrassment, will not bring it up. And that has to be addressed, especially for people who are undergoing planned surgeries in the pelvis or planned radiation to the pelvis. If they are counseled well, and there are drugs which can be used, if these drugs are started well in advance, this problem at least can be reduced in severity.
All right. So the solution you're saying is a different kind of treatment, different drugs.
Simple treatment. The other drugs are not the other drug which is used to treat it, those tablets are not difficult. They can be given safely for a long period of time. There are so many diabetics and patients with heart problems and hypertension problems. They take these medicines quite routinely. So for a cancer patient, they are not going to cause too many side effects. Only thing is, it has to be brought up. So it has a major impact on the patient's psychological well-being as well as his fertility. That unable to perform, it becomes a big embarrassment for the patient. And these patients don't bring it up. They feel that, well, this is not an oncologist domain, so we should not tell the oncologist. And they don't see any other doctor out of sheer embarrassment. So this problem has to be thought out, and this problem has to be probed.
All right. Dr. Jaydeep, now I want to try and understand from you that once the entire team of oncologists, the board has decided that, X patient is a suitable candidate for fertility preservation, then how does it work out? Is the staging of the cancer important? And, what are the options available for the patient for fertility preservation?
Thank you, Anisha. I think I'm going to answer your question, but I just want to say this one thing, that for me, fertility preservation is very much a part of reproductive choice. And the problem is that reproductive choice in our country is still not as high on the priority list as it should be. I completely agree with whatever Dr. Deshmukh, Dr. Jyoti, and Dr. Jaydeep Malhotra have said. But I still feel that awareness on the side of the patients, on the relatives, regarding fertility as an important aspect of life, and the fact that they have control over that fertility needs to be emphasized much more than what we are currently doing. As far as what happens after a patient has decided in this instance to undergo fertility preservation, again, this is a fairly nuanced topic which is perhaps not realized. For example, you have a newly married girl at, say, around 25 or 26. She's had a diagnosis of cancer. Now she's come to you for fertility preservation. One of the nuances that you need to talk to her is whether you are going to freeze her oocytes, that means her eggs, or whether you're going to freeze her embryos. This actually speaks to reproductive autonomy. Cancer is going to affect her life in a very significant way. Don't you want to give this woman a choice? Say, for example, her marriage runs into trouble because of whatever reasons, either cancer or any other kind of reason. Don't you want her to have the reproductive autonomy to choose the gametes of the partner whom she will engage with later on? So although it is a sort of a knee-jerk reaction to say that, oh, she's married, let's make egg, let's put the egg and embryo together and freeze the embryos. I think we need to pause and think over here about her reproductive autonomy. And rather than talking about freezing embryos, start talking about freezing her eggs. And that makes sure that she has the reproductive autonomy to choose her partner in the future in case downstream something goes wrong with her marriage. The other options, of course, are there. There is embryo cryopreservation, where we make the lady grow her eggs. And I must again emphasize that this is not necessarily a very lengthy process. This can take place in 10 to 15 days. And the woman can actually start undergoing treatment for her cancer within 10 to 15 days of having her eggs retrieved. You can either freeze her oocytes, that's her eggs, or you can freeze her embryos. You have to speak to her and decide what to do. Personally, particularly at a younger age, I would always prefer to freeze eggs rather than embryos, because for me, it's a matter of reproductive autonomy. And of course, there are other options like oocyte tissue cryopreservation, etc. But I would have to say that in routine clinical practice, most of the times what happens is when a woman comes to us for fertility preservation, we stimulate her eggs, we remove the eggs from her body using a transvaginal ultrasound, that means a sonography that is done from below. And then we freeze either her eggs or embryos. And if it's a male who comes to us, then we try to collect a few semen samples. And if there is no time to collect 2 or 3 samples also, it is relatively easy to remove the tissue from the testes of the male and then cryopreserve that. The results of that are also very, very good. So these are essentially the 2 options that patients have when they make a diagnosis of cancer and then they come to us for fertility preservation. There are other more esoteric ways of fertility preservation, but as I said, those are esoteric. These are the 2 most practical ways of preserving fertility. I also have to say that fertility preservation does not only mean freezing the gametes. Fertility preservation could extend, for example, during surgery. If there is a tumor on one side of the ovary, you could preserve the other ovary and treat that one ovary, leave the other ovary behind, let her have her fertility, and then remove the other ovary later. Of course, this depends on the stage of cancer and everything. This is not something which can be applied in a blanket formation, but fertility preservation is not restricted only to the IVF laboratory. Fertility preservation is a fairly large and complex topic, and it could also be fertility preservation in terms of in vivo, that means within the body gamete preservation.
Within the body, okay. And that's, I think, something we had not really heard that much about, new scientific frontier perhaps. Dr. Jyoti, what can be done in case, if a lady has, say, breast cancer, will her uterus get affected? I mean, you may freeze her eggs and, later they can be used in an IVF procedure to produce embryos. But if I have breast cancer and I undergo therapy, is there a chance that my uterus gets affected? What happens in such cases? Because, Dr. Chetan Deshmukh also spoke about erectile dysfunction, which can be treated with a tablet should it arise because of cancer treatment. But what happens in such situation? Will the uterus be affected as well?
So uterus per se as an organ will not get affected. But just that, there would be premature ovarian insufficiency as a result of breast cancer treatment with chemotherapy. And that's exactly why we talk about fertility preservation before we start the chemotherapy for breast cancer. And that's exactly the reason why those 10 to 14 days are very crucial for patient to undergo ovarian stimulation and followed by oocyte or embryo cryopreservation. And also we have to then take steps for gonadal preservation. So we protect ovarian function through injections also. We start those injections just before the chemotherapy onset and continue those injections once in a month throughout the period of chemotherapy. And once the patient has finished chemotherapy, we then stop those injections. The patient is on follow-up. And whenever we feel now the patient is safe to undergo, pregnancy, can think of, producing or having a baby, then, that fertility preservation that we undertook some many months or a few years ago would become, useful and fruitful now. So it's very important to discuss with the right patient. And breast cancer, it's very well proven that once they have survived the breast cancer, they can have very successful pregnancy outcomes. It's proven in systematic review, it's proven in meta-analysis that the subsequent pregnancy outcome will be good, will not affect the woman's chances of surviving, and the baby will also be good. Just that, will need more closer monitoring during pregnancy. Just that there will be a little higher risk of having a low birth weight baby or small for age baby. But otherwise, the risk of congenital malformations is not increased. The risk of breast cancer recurrence is not increased by having a baby at the right time after completion of the breast cancer treatment. So that's also very important to know. And therefore, the patient should never be discouraged about having a baby after the patient has completed the breast cancer treatment at least, or treatment for other cancers.
All right. Dr. Malhotra, then a subsequent question then, you see all kinds of fertility patients, those who have cancer, those who don't have cancer. Do cancer patients come to you and say, okay, I'll get this fertility preservation done, as you have said, as my oncologist has said, but is it really going to be useful? Will I, in the end, will this treatment work for me? Because I would have undergone cancer treatment. Dr. Jyoti is saying for breast cancer patients, there is no risk. Your functions are good enough for you to have a baby later. Is this true for other cancers? Do patients ask you this question? Preservation to kara lenge, but aage chal ke faida hoga?
Yeah, this is one question. I think I normally answer it like, you do insurance now. Will you use it? It's exactly like that, because you may need it, you may not need it, but you always have it. And it's the choice is theirs. But yes, our job is to give them information that, this is something which they can do it, because especially when we looking at, let's say, breast cancer in a young patient, or let's say leukemias in very young patients, where or some pituitary tumors, after surgery survival is very good. That these are the patients where the risk is low, or the preservation or the longevity is there, and they will work. The problem arises especially in patients where some heritable issues are there, or heritable diseases are there. Those are the issues which we need to have a much longer counseling sessions which are required, and maybe involvement of a few more people, geneticists or onco people should be there on board.
All right. Dr. Deshmukh, Dr. Malhotra is saying that, of course, the team has to assess the risk to fertility of cancer treatments and then suggest preservation. But statistically speaking, do they stand as good a chance as those who have taken fertility treatment who didn't have cancer? Does having cancer, impact infertility even after preservation?
I agree. There will be definitely some impact of both disease as well as cancer treatment. Cancer treatment directly as a result of cytotoxicity, as Dr. Jyoti rightly pointed out, you may end up having premature ovarian failure. The ovarian reserve is limited. It's going to last only for a certain number of years. That will definitely affect, most of the drugs will definitely affect it in some way or the other. So especially women who are in their late 30s or early 40s, their chances of having fertility preservation are going to be much less than a comparable lady who doesn't have cancer or has not undergone any cancer treatment. So definitely cancer and its treatment will have an impact, and they would affect fertility preservation, no doubt about it.
All right. Also, just for the sake of understanding of those who are watching, are there any legal issues of fertility preservation that patients should be aware of? Who would like to address this? Would you like to address this, Dr. Wadhwa? Dr. Wadhwa, I'll repeat the question.
More competent in legal matters should answer this question.
Yeah. Would you like to take a shot at that, Dr. Jaydeep?
I'm not necessarily competent, but practically speaking, I think I would say that, of course, this is a medico-legal minefield. Not the least because when somebody undergoes fertility cryopreservation, has taken time off from cancer treatment, and then undergone this, spent money on this, one can understand that the expectations of the outcome of this fertility preservation are going to be very high, which is understandable. And that's why I think what Dr. Jaydeep Malhotra, Jyoti, and Dr. Chetan Deshmukh have very clearly said is that counseling is key, and so is consent. The problem, however, remains that, as I said, it is a medico-legal minefield because what you say may not necessarily be interpreted in the right way by the patient. A patient might take it to mean that I've preserved my oocytes, which means that I will have a baby. But the fact that oocyte cryopreservation or even sperm cryopreservation is not a panacea. And that has to be made very clear to the patient. And it is a fine line that, everybody who counsels the patient has to walk between reassuring the patient and not making tall claims or not making claims which are falsely reassuring. It's like, when you sit in a plane, the pilot tells you, have a nice flight. The pilot doesn't tell you that you are in a, aluminum tube a mile above the Earth's surface, and if one part goes wrong, you could, flame and so on and so forth. So it's a very difficult situation medico-legally, and the key really is a good understanding of the patient by counseling, and of course, a thorough and adequate documentation in terms of consent, etc. And at the end of the day, being quite honest and open to the patient. So, for example, if the patient asks you, doctor, what are my chances that I will have a baby? I've preserved my eggs with you. What are my chances I'll have a baby? Because that's why I'm preserving the eggs with you. It's not an academic exercise. You have to tell the patient that when you have around 18 oocytes or 18 eggs cryopreserved with you, the chances that she will get pregnant with one or multiple attempts of IVF in the future will be quite high, which is 80 to 90%. But it also means that 10 to 20% of those who cryopreserve oocytes will not get pregnant. And sometimes that second part is something which the patient either ignores because the patient is putting in that much effort and taking time off from cancer treatment, or forgets over a period of time. As Jaydeep, my senior colleague in Foxy, and I've had the pleasure of working with Jaydeep so often, quite rightly said, it's like insurance. When we buy insurance, we assume that that insurance will be useful to us. But when we put in a claim and that claim gets rejected, that is when all the problems with the ombudsman and etc. start. So briefly to answer your question, it is a complex medico-legal matter, and the key really to avoid medico-legal problems is counseling and adequate documentation and consenting.
Can I add in here, Anisha? There are many
Dr.
other
Malhotra,
things.
I'll also request you to please give us an approximate estimate of what is the cost of preservation as well.
Yeah. No, before that, can I just address, because there are many other issues in legalities, because there are issues in legality, regulations are not in place. If you have preserved, let's say, and the sample doesn't come out well, then who's responsible? Which is again a very, very important issue. It's not only about then disposition. I have at least, 2 sets of eggs lying with me for the last 10 years, where nobody has come to claim. I have written a number of letters that, would you require, there's no reply. If I dispose them off and then, somebody comes to claim them, what do I do? So there are hundreds of issues like this which are there. There are no insurances, covering this up. And supposing who claims these gametes later on? There are thousands and thousands of issues which are there, which we need to also understand. Now, coming to your question about the financials. The financials, I would say, as for a male, they're not as much, because semen preservation, as I told you, is very, very simple. And it may just cost about 5,000 to 10,000 rupees for, a sample preservation. But maintenance of the samples, the cost may change from clinic to clinic. And that is something which is important. Especially for female fertility preservation, again, the costs are going to be different, whether it's only oocyte preservation, whether it's an embryo preservation, whether it's ovarian tissue preservation, which will require surgery, plus, special treatment of the tissue which is there, and then preservation, plus, don't forget, as I'm saying, insurance. I think that is very, very important, because you cannot tomorrow say, plus safety. Safety is another very important question. Like, how is this tissue going to really perform, and will it really bring about the problem again? So all these, the costs will vary according to what we are doing in what circumstances. Like we do dual stimulation for women who have shorter time in between the surgeries, like she's been operated for breast cancer, and there is still time for chemotherapy to start. In between, time is utilized for preserving as much number of eggs as possible. So costs depend on that, but I still feel that it's not as much, because tomorrow we are enabling them to have a baby of their own. And that is what matters. Because what is one cycle of IVF costing anywhere? I mean, it's simply that we are just taking the eggs out or the tissue out and preserving maybe 1.5 lakh to 3 lakh of rupees. Now, maintenance, as I said, in my clinic, I can tell you that for 2 years maintenance, we charge 25,000 rupees for 2 years. So people can renew it year after every 2 years. So it's not as much, but having a baby of your own is something which is really important.
It's a joy that you cannot put a price tag on. And, at that point of time, cancer patients may not be thinking this far ahead. But when they struggle, then they will realize, how parenthood can affect them and how families can affect them. If they have beaten cancer, they would also want to live completely and fully. I'd like to thank all of you for taking the time out to join us and talk about this very, very pertinent and important question. And I hope we have cleared the air for a number of cancer patients who may be, going through treatment and not thinking about these things. So if your oncologist has not suggested, perhaps you should have a chat with them about this, should you feel that this is something you care about. And thank you all for joining us. Thanks to all the viewers for giving us the time. And we will wrap it up here. And I want to thank all our speakers for coming in. And they've shared the latest advances in cancer care treatment and fertility preservation, and what are the options available for the patients to think about and then go ahead with, should they choose to. I've learned a lot, and I'm sure that the audience has also benefited a lot from this discussion. This program was supported by CIPLA. Do follow us on Facebook to get all the updates on our upcoming programs. We will wrap up the show here. Till we meet again, stay safe, stay healthy, and take care. Goodbye and see you soon.
Thank you.
Goodbye.